Alright guys, we're going to talk about antipsychotics and focus on schizophrenia this lecture. The definition DSM-5 for schizophrenia is here. And so you're looking at a month of one of these, or two or more of the following. The pictures here, in case you're wondering, are called the Wayne Katz paintings, and they're this guy that painted his cats, and there's some speculation that he had schizophrenia, and so people have used this as kind of a progression into, kind of his descent into madness, if you will, and the different views of his cats. People have argued that that's not actually accurate, and he was just painting wallpaper designs or something like that. But either way, these two cats certainly are a little bit creepy, and this one kind of looks like some kind of a demon, so I think it's a fun story. But yeah, so schizophrenia, I think people think of schizophrenia and they think split personalities and stuff like that, but really, I mean, you kind of break it down here, and that's essentially delusions. So delusion is a fixed false belief in something. Hallucinations most commonly are auditory, so hearing voices is going to be a lot more common than seeing things, although certainly you can see things. Disorganized speech, grossly disorganized behavior, negative symptoms. So if you ever heard the term flat affect, if you ever do a psych rotation or meet somebody who has a flat affect, you'll never forget what it's like. It's just not only monotone, but just kind of like there's no reaction to things. And then social occupational dysfunction, obviously based on these things, it'd be very hard to hold a job or a position in society that's functional. So schizophrenia itself is incredibly disabling to people, and it's something that treatment can help with, but can't always fix all the problems. So anyway, we'll talk about it. Here's my joke. It's not paranoia if the cappuccino is really out to get you. Okay, so epidemiology, about 1% of the population experiences some sort of schizophrenia or schizo-like disorder. It's similar among all different cultures globally, and similar rates between men, women, slightly more common in men. Age onset's kind of an interesting thing to discuss. For men, it tends to be younger onset, and women, it tends to be a little bit older, but both genders, it's young-ish. So for men, you usually see onset in the late teens, early 20s. For women, you usually see onset kind of in the mid to late 20s and even into the early 30s. You can have later onset schizophrenia as well. It's just not as common. And you can have schizophrenic-like behaviors due to other situations. So for example, like advanced Alzheimer's can pose some schizophrenic-like behaviors, even though it's not technically schizophrenia. And then treatment with Parkinson's drugs, like we talked about with Sinemet, can cause psychosis and things of that nature. Drugs of abuse certainly can cause schizophrenic-like behaviors as well. So, but pure schizophrenia, as far as the actual disease that affects people, is kind of an interesting pathophysiology and interesting epidemiology, because there's no real understanding between why it happens to people. There's some family history potentially, but other than that, that's not even a very strong link. So we don't really know why people become schizophrenic. The largest cause of death among schizophrenic patients is suicide. So due to the delusions, the belief that something's out to get them, or the voices telling them to hurt themselves, over time, if they aren't treated, about 10% will actually successfully commit suicide. 20 to 40% will actually attempt suicide. So it's a huge numbers. So schizophrenia, certainly, these patients are, I think people kind of get scared when they think about a schizophrenic patient being a danger to society, but they're much more likely to be a danger to themselves than anyone else. Certainly there are violent examples, but overall, much more likely to be a danger to themselves. 20% reduction in life expectancy compared to somebody without schizophrenia. Substance abuse rates are quite high across the board. Smoking is certainly quite high. There's been some studies that say that like 75% of people smoke cigarettes. There's other studies that say that it's not actually true, but certainly there are generally trends in higher substance rates with schizophrenic patients. And again, we don't know what causes it. Stages of schizophrenia, so prodromal, acute, stabilization, and stable. Prodromal is your gradual symptom development. Kind of goes unnoticed, so the patient slowly isolates. You see deterioration of hygiene, loss of interest in certain things, dysphoria, lack of pleasure in life. Acute phase, they have a more full-out psychotic episode accompanied by basically complete lack of care for oneself, so this stuff kind of degrading further. Stabilization would mean once they're treated or out of this acute phase, the symptoms kind of decrease over several months. Stable, symptoms gone. Depression or anxiety may still be present. Completely getting somebody into remission from schizophrenia is very difficult to do. The drugs we have are sometimes effective and sometimes they're only partially effective. So you might have residual side effects or symptoms or things that just you can't get rid of with certain schizophrenic patients. There's two major groups of antipsychotics. They were called atypical and typical. The typical antipsychotics were the first generation, and the atypical antipsychotics are now known as second generation. So I'll use the term second generation, first generation. I think it's a little easier to think about it. It's easier to remember which ones are the old ones, the first generation, which ones are the new ones, second generation. The development of these agents dramatically changed mental health treatment. Before you had drugs, basically your options were to institutionalize someone, and there's some arguments that once the drugs came out, people oversold them a little bit, push people out of mental hospitalization when they probably should have been hospitalized. So anyway, that's another discussion, but these did change because before this you really had institutionalizing people, and then you had other behavioral therapies, like things like electroconvulsive therapy, which we actually still use today in certain cases, but other less savory things like insulin coma induction, where you basically would give somebody insulin until their blood sugar was so low they'd essentially get a seizure from it. Lobotomies. So obviously we don't do these two things anymore due to their risks, but that was some of the options early on in mental health treatment before there was any type of pharmaceutical intervention and before behavioral therapy was as advanced as it is now. All right, this chart is a lot to take in probably, and you're probably like, what is all this stuff? But essentially on the side here you have all of the antipsychotics on the market right now. Maybe a couple exceptions. I think there might be a couple newer ones I didn't add here, but that's okay. Doesn't really matter. The point of this is that you can see all the different receptors they interact with. So the interesting thing with antipsychotics compared to like an SSRI, well, SSRIs basically do one thing, right? They interact with a specific type of serotonin reuptake channel, block it, and then you don't get reuptake. These drugs have a number of different activity on different receptors. They mostly act as antagonists. They block different receptors. And so one of the major pathophysiologies behind why people have schizophrenia and these intrusive thoughts or voices that they hear is an over, and I'll talk about this in the next slide, so maybe I'm jumping the gun, but is an over expression of dopamine in certain areas of the brain. So for example, if you look at the drug, most of these drugs actually have some component of dopamine antagonism, and also some component of serotonin antagonism in certain areas of the brain. If you compare these, so these drugs are all second generation antipsychotics. The two at the bottom, haloperidol and perfenazine, are first generation. And you can see that they're much more focused on the dopamine side with lesser versions of the serotonin, or lesser amounts of serotonin receptors. And they're a little bit cleaner in profile. If you really break them down, they do quite a bit of the same thing, but they're much more focused on the dopamine side of things. So when you think about a first generation antipsychotic, think about it as a more simpler mechanism of action. They essentially block overactivity of dopamine in certain areas of the brain. They don't really do much else, whereas the newer drugs actually have more of a focus on serotonin activity, and then they also balance that with the dopamine too. So what does this all mean? Two different areas of the brain we're going to talk about right now, mesocortical and mesolimbic. The mesocortical pathway Mesolimbic pathways are responsible for memory, motivation, reward, desire, addiction. Dopamine hypoactivity can cause negative symptoms in the mesocortical pathway, and in the mesolimbic pathway, dopamine hyperactivity causes positive symptoms. So a negative symptom can be defined as something that should be there but isn't. So flat affect's a great example of a negative symptom. The person is monotone, they don't really have much emotion in their voice or anything like that. That's a negative symptom. A positive symptom is something that is there but shouldn't be. So an intrusive thought, a voice, things like that. So the tricky part of this, as you might imagine, is how do you do both things? How do you increase dopamine activity in the mesocortical pathway and decrease dopamine activity in the mesolimbic pathway? And that's been kind of the trick to balancing schizophrenic drug therapy. And so when the first drugs came out, the early ones, the first generations, are all focused on anti-dopaminergic effects. So they're dopamine blockers, and they block it in the mesolimbic pathway. Well, that doesn't really do anything for the negative symptoms. In fact, it might exacerbate them a little bit. It might make the patient more sedated as well. The other thing to think about, too, are a couple other pathways involved. So there's something called the nigrostriatal pathway, which is involved in motor control. Death of neurons in this area is responsible for Parkinson's disease. So if you're blocking dopamine activity in that area, even if you don't have Parkinson's disease, you're going to end up with movement-related, so you call it Parkinsonism-like symptoms, and that's a common side effect, especially with the older first-generation antipsychotics. And then this other pathway here has some hormonal regulations and things like that, which can cause various issues, such as increasing prolactin production and things like that. So the point in me showing you all this is that managing these symptoms of schizophrenia is very difficult to do because there's a lot of complicated mechanisms going on in the brain, and also there's a lot of side effects that happen when you try to manipulate some of these areas. And this just kind of restates this, talking about the dopamine pathway. The serotonin pathway, so if you're wondering, what about blocking serotonin, it's thought that certain overexpressions of serotonin, if you have serotonin antagonism in certain areas of the brain, you might improve mood, memory, processing, sleep, and cognition. Just to summarize it a little bit and look at side effects. So if you antagonize dopamine receptors, you end up with your extrapyramidal side effects. You end up with prolactin elevation. That's from that other pathway that affects that. EPS we talked about with the anti-nausea medications already, because they're basically they are kind of analogs of antipsychotics, or in some cases they were developed as antipsychotics at one point in time. Serotonin can cause nausea, sexual dysfunction, orthostatic hypotension, weight gain. Adrenergic effects, orthostatic hypotension. Histamine effects can cause sedation and weight gain. It's thought that if histamine has some sort of appetite function in the central nervous system, some of these drugs do cause quite a bit of weight gain when people take them, and it's thought that it's increasing their appetite via some sort of indirect manipulation of the histamine receptor, or direct manipulation of the histamine receptor, I should say. And then acetylcholine. So these drugs have a tendency to be kind of on the anticholinergic side. All right, side effects. So this is a lot probably to look at, but the side effects of these drugs are really kind of what makes you choose one or the other. And the other point of showing this is that these drugs are, again, not clean. They have lots of side effects. Newer agents tend to be a little bit better. So, for example, aripiprazole is Abilify. That one has very little side effects across the board. A little bit sedating, a little bit of EPS, usually dose related, but other than that, not too much. Compare that to Clozapine, which is an older drug. You have heavy weight gain, sedation, anticholinergic, orthostatic. So a lot of mixed bag. We're going to go through these drugs in more detail and kind of point out some of the details, but this is a good reference. We talked about this briefly for antiemetics, but extrapyramidal symptoms, so these are your movement disorders. Akathisia, which is like an inner restlessness, Parkinsonism or Parkinson-like symptoms, and dystonias. This is associated with acute antipsychotic use, so this happens quickly, and it's treatable by just stopping the antipsychotic and reversible. Tardive dyskinesia, or TD, occurs after about 6 months to even years into treatment it can occur, and people usually develop involuntary facial movements, so sucking, lip smacking, tongue movement. You can have jerking and movement of other extremities, truncal areas, but it's more common to see facial expression of that. If this happens, it's usually irreversible. First generation antipsychotics, aka typical antipsychotics. We'll talk about these very briefly. These have mostly fallen out of favor because they have a very high risk of extrapyramidal symptoms and they're fairly sedating. They aren't really used first line for maintenance purposes. They are effective, however, just with their side effect profiles, second generations are almost always approved or preferred, and these really only get used if people don't respond well to second generation or in emergency situations. So, for example, haloperidol is probably the most commonly used one. It's really used mostly as a acute agitation treatment for patients, and even then it's kind of falling out of favor just because of the side effects it causes. It's highly sedating and it lasts quite a long time. You will see people occasionally on it chronically, but again, it's probably because they've failed second generation medications. It does come as a long-acting intramuscular formulation. These are nice, especially for people who have history of adherence problems. You can give them a once monthly shot, and then that gives them a whole month of therapeutic levels of the drug. Some other first generation antipsychotics are here. I don't really care, you know them. Talked about chlorpromazine a bit already. Perfenazine, I'll just mention briefly. There's this trial that came out called the Katie trial. So when the second generation antipsychotics first came to market, there were a few of them and they were very expensive, and so all these people were like, is this really worth it? And the Katie trial basically said that perfenazine is as effective as any second generation antipsychotic for managing schizophrenic symptoms. However, people reported more EPS. Now, perfenazine is kind of an intermediate potency agent, so it's not going to cause as bad of EPS symptoms as haloperidol, but it is something to consider. So overall, the trend has been significantly to avoid first generation antipsychotics unless you have a good reason to do so. They are relatively cheap, but then again, most of the second generations that were the original group have gone generic and are pretty inexpensive too. If you did want to give a first generation, you do have to consider EPS prevention. So the two drugs that are most commonly used are diphenhydramine, Benadryl, and this is usually used in the acute phase. So, for example, if somebody's really agitated and you give them intramuscular haloperidol, you usually give them intramuscular diphenhydramine as well to prevent EPS. I don't know how true this is, and I honestly haven't read studies about this, but I've heard from a number of my ER physician colleagues that say, and nurse colleagues that'll say that, yeah, if you give somebody haloperidol and they get EPS, it's very difficult to do anything about that. You just have to wait till it wears off, essentially. But if you pre-medicate them with Benadryl beforehand, you almost never see it. So now, whether that's almost never or not, with Haldol, it's probably much more likely. With a medication like metoclopramide or prochlorperazine, certainly lower risk. Benztropine is cogentin, and that's a little bit less sedating than diphenhydramine, and it's much more commonly used in people who take haloperidol regularly. So if you're on a first generation antipsychotic and you take it every day, you usually take benztropine as well to prevent the side effects associated with it. All right, second generations. No particular order here, but we'll start with risperidone or risperidol. Paliperidone is an analog of this that came up more recently called Invega, and it's just the active metabolite. There's really no difference in efficacy. Risperidone is actually a pretty popular initial antipsychotic. It's generic, it's been around a while, it's pretty effective. It's kind of a middle range. It's not maybe the most effective out there, but it also doesn't have the worst side effect profile associated with it, and it's pretty cheap. It also comes as a long-acting intramuscular injection, which is a nice option if you wanted to convert somebody from oral to long-acting if you needed to. Side effects are lower on the lower spectrum, but they are there. Most commonly dose-related EPS, and then higher incidence of hyperprolactinemia than other antipsychotics. That's one of the more common drugs that causes this particular side effect. So that can cause in men, specifically gynecomastia. In women, it can have menstrual-related issues and other things like that. Anyway, both drugs come in long-acting IM forms. Invega, as a long-acting drug, is really popular. Invega Sustenna. It's a once-monthly drug. It requires no bridging, so basically you just have to start somebody on paliperidone, get them to a therapeutic dose on it, and then you can convert them over to the IM. Whereas with Risperdal, the constant injection, you have to do a 3-week bridge between oral and IM. So Invega Sustenna has become very, very popular. It's probably the most popular IM long-acting that we use at our hospital. Olanzapine is Zyprexa. Zyprexa is what a lot of people consider to be the gold standard when it comes to treatment of schizophrenic symptoms and when it comes to comparing things to second-generation antipsychotics. A lot of new drugs can't really have been tested against olanzapine, but they can't really prove superiority, and at best they can say they're as good as olanzapine. Olanzapine comes in a bunch of different forms: PO, ODT, IM, and an IM long-acting as well. You can use it in acute situations. So what I said, haloperidol is kind of falling out of favor for acute agitation. It's actually been replaced mostly by injectable Zyprexa as a acute medication to stop agitation. So it's become much more popular there. It is generic, so it's relatively inexpensive. And then again, this is kind of shifting away from dopamine towards serotonin antagonism. Side effect profile: minimal EPS with olanzapine. In fact, you really don't see it at all. However, you do get significant weight gain, sedation, and hypotension. So in the acute phase, we don't care about this stuff, because if you have somebody acutely agitated, you probably want them sedated. You don't really care too much about the hypotension, and the weight gain isn't going to take place until they're on it chronically. So Zyprexa is kind of fallen out of favor as a chronic day-to-day med, although it's still used by people who have failed other therapies. It's certainly not a first-line option. However, it is a first-line option for acute use and acute agitation. Quetiapine is Seroquel, which, if you look back to our charts earlier, it has a really weak affinity for a lot of receptors, but we give it at higher doses. So, for example, with Zyprexa or olanzapine, you give it between 5 and 20 milligrams or 30 milligrams. Seroquel, you can give anywhere from, people take really low doses of it, like 25 milligrams, up until like 900 milligrams. So there's huge dose ranges with Seroquel. The side effect profile: weight gain, sedation, QTC prolongation are the big ones. It's also anticholinergic. I should put that on here. And that's an important one, because I think quetiapine is probably the most popular choice for agitated elderly patients, giving really low doses of quetiapine. It's also a really popular choice for sleep in elderly patients. And for those reasons, the anticholinergic side effects can kind of stack up on those people. It's used really commonly for as an as-needed medication. Like, people might take a little bit of Seroquel on top of something as like a as-needed for anxiety or something like that. It's one of the best second generations for psychosis caused by Parkinson's disease treatments. Very low incidence of EPS. It is generic, but there's a XR formulation, which I think is now generic. I think it's been a while since that's been brand name. So there's that. And again, people use this as a sleep aid for low dose. Ziprasidone is Geodon. Geodon has a pretty good side effect profile. There's no weight gain, very little EPS. It is activating too, so it's one of the few that's not directly sedating, which, depending on how you want to manage your patient, may be a pro or a con. Sometimes you want your patient to be maybe a little bit more sedated, at least at first, if they're really kind of wound up from their disease. It's generic. QTC prolongation gets quite a bit of attention for this, but quetiapine and elaperidone have the same side effect with that, so there's really no difference. It is available IM for acute psychosis, but we generally use olanzapine because it's more effective and it's less expensive. It does have some serotonin norepinephrine reuptake inhibition, and so for people who have a comorbidity of depression, it can be a useful drug to try. Not as popular, just one I don't see used quite as much, but certainly an okay option. Aripiprazole is Abilify, which is the most recent one of this group to go generic. It was brand name till maybe, I don't know, just a couple of years ago. It's one of the top-selling medications in the country consistently for several years in a row. So that says something about its use. A very widely used medication. Good side effect profile. Has some serotonin reuptake, kind of like Geodon. And it's just the reason why it's been so popular is it's gotten a lot of use in adjunct therapies. So as far as treatment for treatment-resistant depression, anxiety, bipolar, and as far as using it for schizophrenia, it is used for that still, but it's often used as a second line or third line agent in these diseases, and that's why it's become so popular, because so many people take it for that versus schizophrenia, because there aren't that many schizophrenic patients compared to patients with depression. It's not as efficacious for positive negative symptoms when compared to other mainstream second generation antipsychotics, but again, it is effective. There's a newer option called brexpiprazole or Rexulti that is getting advertised right now. I'm not sure if there's any advantages, and it kind of falls in the category again of newer meds that you try if other things aren't working. I want to talk about Clozapine a little bit. It's an interesting drug that I put together a little case on. So this is actually a patient that I got to work with when I did a rotation at the VA in St. Cloud in their mental health wing. And it illustrates kind of the idea behind this drug. I'm not spending a lot of time on Clozapine because it's really common, but it's an interesting medication, and I think it's worth a little bit of time. So anyway, this was a 56-year-old white female. She has a chronic paranoid schizophrenic. She followed up with the St. Cloud VA, and she presented with initially with an intense fear of a person she referred to as Mr. Menard, who she thought was actually John Menard, who's like the Menards founder guy, and she was found arming herself for protection, compulsively checking the locks in her room. She had a pretty significant antipsychotic history. Fluphenazine, thiothiazine is another first-generation antipsychotic. She'd been on olanzapine, risperidone, Consta, and aripiprazole. All these doses are really high, just for reference. So she was on pretty significant doses of all the medications. And she had a history of medication noncompliance, hence trying the long-acting IM injection. So when she presented, she was on Abilify at the time of presentation. So you can see she'd finally gotten to Abilify, tried a number of other things, still didn't seem to be working. So she was still having paranoia. She had appropriate affect and sleep habits, however, but she did... Oops, sorry, I'm kind of getting ahead of myself here, backing up and rehashing her case. Anyway, she's hospitalized for a month, and she started a medication called Clozapine. Clozapine is a second-generation antipsychotic, but it's one of the older ones on the market, and all of her symptoms basically improved over a month of hospital stay. So why did we try Clozapine after all these other medications? Well, about 25 to 50% of people do not respond to, I should say, instead of typical first-generation agents. And then some similar results have been found for people who don't have with resistance to second-generation treatment. So basically, any patient who has resistance to a antipsychotic, Clozapine is a consideration. But that's the only thing it's approved for. So it's only approved for treatment-resistant schizophrenia. It's a very effective option, but there's a lot of side effects associated with it as well, and a lot of red tape to get through. So if you end up working in mental health, you're going to have to understand some more of this. Clozapine is probably the worst side effect profile of any of the second generations. You can see all the side effects there. The big one is agranulocytosis, which is a profound neutropenia, and that's why regular monitoring is required to be on Clozapine. So best case scenario, you're monitored once a month. So when you start somebody, you have to check their, and this is a little bit outdated actually, we don't check white blood cell counts anymore, we just check ANC. Get rid of that. But basically you check weekly for 6 months, and if everything's going well, if your ANC is fine, then you go every 2 weeks, and then you can go every 4 weeks after that, and then you can be that indefinitely. But that's basically it. You can never go less than 4 weeks as your frequency. So these people who are on Clozapine regularly have to always follow up with some kind of a lab monitoring system. And you can see this too. What do you do if somebody does dip into the other levels of ANC monitoring? You can have different parameters as far as how you check, and when you check daily and when you actually stop. So agranulocytosis is defined as ANC below 500. It's very rare to actually see this on Clozapine, but that's why. But it can be devastating to the patient, put them at risk for opportunistic infections and things like that. So this patient, CS, got discharged, was approved for a trial of Clozapine with weekly outpatient monitoring, and she happened to return to clinic with her ANC of 1400, which puts her right in the moderate leukopenia or granulocytopenia. And this is just a trend on when she started Clozapine and when she dipped. So the question is what can you do with Clozapine? There's a lot of different options. Most of them there's some gray area, but there's pretty specific recommendations to what to do. Rechallenging is always risky. If somebody does get to a point where the guidelines would recommend not rechallenging them, you might have to document that you have to do it, because sometimes they're like, there's nothing else that's working for this patient. This is literally the only thing between them and being institutionalized for the rest of their life. Sometimes they give people lithium. Lithium we'll talk about during the bipolar lecture, but it's a bipolar medication that can help as a mood stabilizing agent, but it also can increase neutrophil count. And there's some information there for you. I don't really want you to know much about that other than that this patient basically got lithium added onto their effect. So they got lithium. Her ANC actually dipped right to 1,000, right on the nose there, and that means that per the guidelines, you wouldn't actually rechallenge. Now you can rechallenge, so even it's not an absolute, but the psychiatrist prescribing would have to go through some hoops to make sure that rechallenge is documented correctly. Anyway, after this, she was able, as you can see, her ANC trended up, and she did just fine after that. So it's really that one dip that caused her all the drama. But when I followed up with her, she lived at the end of my rotation. She had lived on her own. She had a VA appointed case manager, and she had pretty much essentially a normal life. Some still residual symptoms, and again, it's very hard to get rid of every symptom of schizophrenia, but the drug was clearly working for her in a way that none of her other medications had. So certainly an interesting case study in showing that, one, how difficult it can be to treat a schizophrenic patient with multiple medication trials over years of time, and two, even if you find that right medication combination, you still have to worry about the side effects and the monitoring and things like that, and then thinking about Clozapine as a further agent as an option for treatment-resistant schizophrenia. All right. Newer agents. So newer agents are still considered second generation. They're all kind of varying in their receptor profile, just like all of the other second generation agents, but they're essentially similar concepts. So the new ones are lurasidone, acenapine, iloperidone, brexpiprazole, and cariprazine or Vraylar. I don't really have a ton to say about any of these. Not to say they don't get used, they actually are pretty common, just because again, schizophrenia is so hard to manage that any new agent is going to get a significant amount of use, just because there's plenty of people out there who have tried almost everything else, and either the side effects don't allow them to be on it, or they just aren't working ideally. So there's always an appetite out there to try a new medication. Latuda is by far the most popular one. It's kind of taken arapiprazole's old throne of the cross use in pretty much every mental health indication, so treatment-resistant depression, bipolar adjunct, all those things. Lurasidone is getting used. Lurasidone was actually studied in a pregnancy. Got some pregnancy data, I think, in animal models that showed that it was less toxic. So it's actually the only category B antipsychotic in pregnancy. It's one of the better tolerated ones. It has some marketing data around it saying it's got pro-cognitive benefits. I don't know if that's really true or not. I think their studies on that are a little bit weak. The other ones I don't really have much to say on. Again, varying different degrees of use, as far as basically like, okay, you haven't tried this, well, let's give this one a shot. It's new, maybe it'll work for you. So, is there a perfect antipsychotic? Well, ideally, your perfect antipsychotic is going to decrease your positive and negative symptoms. It's going to improve your cognitive function, have a limited side effect profile. And while some of our drugs might do that for some patients, we don't have a core category of drugs that does that for everyone, and that's unfortunate because most of our antipsychotics tend to fall short in some of those areas. I think we're really good at decreasing positive symptoms. We're okay at combating the negative symptoms. We're not great at improving cognitive function, and our side effect profile still could be improved on the whole. And then there's the economic consideration. When you come out with these new drugs, it's like, are they really that much better? And then they cost 10 times as much as the old generic version. So where do you start? How do you treat these patients? Basically, you can do anything but clozapine or olanzapine. Clozapine, you have to fail therapy before you put somebody on it. Olanzapine causes so much weight gain and metabolic disturbances that you want to avoid it for long-term use. Insurance may dictate which agent you use, especially if you try to prescribe a brand name, but other than that, it's not going to be a huge deal to prescribe many of these. Cross-taper the drugs if you're going to switch. You can use 2 second generations at the same time because the mechanisms are all slightly different, what receptors they hit. So you may see somebody on a combination of 2 different second generations. Don't get too surprised. Sometimes what's also common too is people might be on one chronically and take another one kind of as needed if they need like something for acute agitation. Combination adjuncts for other conditions like antidepressants or other mood stabilizer type medications for bipolar disorder are commonly added as well. If you're treatment resistant, consider clozapine. If you're not compliant, consider long-acting IM products. Pregnancy lactation implementation, just to mention this briefly, minimal risk with both first generation and second generations. Dangers come from having a lot of psychoactive medications combined, and there's some other things on there. I'm not concerned you know pregnancy information for the exam.